Good afternoon and welcome to today's virtual program hosted by the Healthcare Council of Chicago. My name is Megan Phillip. I am the Executive Director of HC3. We are a member-led coalition of healthcare leaders and organizations that are influencing change in our local community. Today's program will focus on the state of the state in Chicago and how we can build a healthier community as part of our ongoing transformation series. It is my absolute pleasure today to introduce Dr. Arwady, who started at the Chicago Department of Public Health in 2015 and served as the Chief Medical Officer before being confirmed by the City Council as Commissioner in January of this year. I don't think it was what she signed up for when 2020 began, but with a career background being at the CDC and IDPH and having firsthand experience in disease outbreaks such as Ebola, I can't imagine Chicago being in better hands throughout this year. So she was recently rightfully named Chicagoan of the Year in 2020 by Chicago Magazine. So without further ado, I'm going to allow Dr. Arwady to say hello and start sharing her presentation.
Thank you so much, Megan, and really thanks to all the members of HC3 for joining today, and more importantly, for all of the work that you and your organizations have been doing this year related to COVID-19, and all of the work that underlies that. And part of my goal today is certainly to talk some about our COVID response, to do a quick overview of the Healthy Chicago 2025 plan, but then really to hopefully have some conversation about how we see those intersecting. And then how we'd like to also think about in your own institutions, how you can carry some of the tenets of Healthy Chicago 2025. So I will share my screen, hopefully here. All right, people able to see that? Presumably, okay. All right, so as I said, the goal is just to do a high-level overview of moving from COVID-19 to Healthy Chicago 2025 and really back and forth. This whole year has been about taking the tenets that we had already set out for Healthy Chicago 2025 and then putting them in practice in a pandemic. And I actually think that a pandemic is a great chance to kind of stress test a plan. You can see which parts come to the forefront. You can think back around how are we trying to live out some of these goals and values even while we are in the middle of a rapid response. And I think it's been an interesting learning venture for us to think about how COVID-19 has made us adapt a lot of our structures and priorities. And the good news is that it's worked very well to take a lot of the Healthy Chicago 2025 work and overlay it with COVID-19. And I hope that for a lot of you in your own institutions, you also have been able to think about where you have goals and priorities, particularly around health equity. You've been able to bring those to light with COVID-19. There we go. So just at the highest level, as you know, in Chicago, we've put a lot of focus on race equity from the very earliest days of the pandemic, formed the Race Equity Rapid Response Team, and have talked really day in, day out. We look at all of our data, certainly divided by age, by gender, by neighborhood, but also quite explicitly by race and ethnicity. And this is our cumulative data. You can see on the left here in Chicago, we're about a third Black, white, and Latinx. But you can see very disproportionately, 46% of the cases to date have been among Latinx Chicagoans. 23% have been among Black non-Latinx, 22% white non-Latinx, 3% Asian, and 5% among people who report other race ethnicity, but non-Latinx. And so we really see how disproportionately, even still, cases are appearing in our Latinx predominant neighborhoods. And that's that blue line you can see running along the top. In comparison on the right, if we look at deaths related to COVID, you see on the left that purple is Black non-Latinx Chicagoans. And that was our first surge where we saw COVID hit the Black community in Chicago just incredibly hard at the beginning of this outbreak from both a cases and a deaths perspective. And even now, 40% of the deaths related to COVID-19 in Chicago have been among Black non-Latinx Chicagoans, even though those rates have come down a lot compared to what we'd seen previously. 34% among Latinx, 21% among white, 4% Asian, 1% other. And so where you see data like this, in a lot of ways, unfortunately, this is somewhat predictable, because we know, and I'm going to show some data in a minute, about the differing rates of chronic diseases, which of course are one of the major things that predict severe outcome and death from COVID. But also, and that's more on the death side, but on the cases side, where we think about what underlies risk for cases, I think COVID has been this opportunity to really see inequities play out in people's faces here in Chicago. And so here, I know a lot of you certainly have been following along. This happens to be this week's test positivity by Chicago zip code, and across the whole city, we're just under a 13% positivity. We'd like that to get back under 5%, but what you can see here is that in the lightest colored zip codes, we have a positivity ranging from below 4% up to 7%, whereas in the darkest blue, our highest quintile, in these zip codes, it's between 20 and 26%. So really twice the positivity that we're seeing across the city. And this has been very disproportionately, really over the last few months, concentrated in the southwest side, the northwest side, and then the far southeast, and a lot of our predominantly Latinx communities. And I know, again, where we see the way, unfortunately, our city is quite segregated by race, ethnicity, where we look at geography, geography often actually can be shorthand in some ways for race, ethnicity. So particularly on the right there, the percent residents that are Latinx, you see a very good overlap with where we're seeing high positivity. And where we start thinking about why that is true, some of this gets down to how easy it is for people to do the things that help keep themselves and their families safe from COVID. One of the most obvious, of course, is the ability to stay home as much as possible. But where we've certainly learned to think a little bit differently about this essential worker term this year, we've done some mapping of where people live in Chicago by occupation. And not surprisingly, we have a lot of higher income Chicagoans who tend to work in office settings, many of whom can more easily transition to stay at home and be able to work from home, living in predominantly white areas of Chicago and on the north side. Whereas here, I put up just for an example, on the left are people working in food preparation and serving related occupations, then building and grounds cleaning, and then transportation. These are all jobs that you cannot do from home. And we see some of the patterns, particularly if you look in the middle there, that buildings and grounds cleaning. The darker blue represents where we have a higher percentage of total occupations. We see that there are parts of the city where there are more people who cannot work from home. That's just one example. There's similar maps if we were to look at crowded housing, right? We recommend that people, if someone has COVID at home, stay in a different bedroom, ideally use a different bathroom. But the maps of where we see crowded housing also overlap a lot with where we have Latinx, heavily Latinx communities in Chicago. So this is where we start thinking about, how these inequities show up. So as this group knows well, the difference between public health and healthcare, they are intertwined, but nevertheless, at the high level, in public health, we're trying to think about the health of populations and communities, especially with a focus on disease prevention. And our interventions tend to be focused on policies and systems and environmental change, really looking toward what can we do at a societal level to create conditions where health is more of the default choice and the population has the highest opportunity to be healthy, whereas healthcare is really about the health of individual patients. Certainly there is some preventive work in there, but much of it is focused on disease treatment. And then the interventions tend to be focused on medical care, really a lot of focus on individual change. And in COVID, these have certainly worked together, but we've made really some remarkable improvements in the healthcare setting, where we look at people now who are admitted to the hospital more likely to survive COVID. But on the public health side, a lot of the underlying inequities, we still have a very, very long way to go. And access to healthcare itself is, of course, also not equitable across the city. And that's something that has really come to light, I think, especially where we think about people who are undocumented. Also, just as a reminder, the factors that influence health. Healthcare is a big part of this, but there's multiple researchers who have looked at this, but the county health rankings use this breakdown in terms of weighting, and it's one of the more accepted breakdowns. 20% of the factors that influence health are about healthcare and access to healthcare. It's really important, but compared to health behaviors and then especially socioeconomic factors, those likely do play a larger role at the macro level in terms of influencing health. And the racial life expectancy gap here in Chicago is what Healthy Chicago 2025 really calls out and is focused on. We've been focused in Chicago on health equity for a number of years at this point, but with Healthy Chicago 2025, meaning our plan that came out in 2020 that will take us through the next 5 years, we specifically called out not just health equity, but really racial health equity and a focus on the racial life expectancy gap. So after decades and decades of increasing, the average life expectancy for all Chicagoans began to decrease beginning in the mid-2010s. That's a really big deal because this is, you can't fudge length of life. And this is one of the strongest indicators for population outcomes across the whole world. And for the first time in the 2010s, we saw this fall from a life expectancy of 77.8 years to 77.2 years. But if we break this down further, we can see that the life expectancy highly variable by race and ethnicity here. So Asian Pacific Islanders, 2012, living almost 86 years, Latinx 83, white 79.8, and then Black much lower at 72.6. As we sort of came forward over the middle of this decade, what we saw was a slight rise in life expectancy among white non-Latinx in the red line there from 79.8 to 80.2. But we saw all other race ethnicities drop in terms of life expectancy, significant drops. And for the first time, seeing life expectancy for Latinx or Hispanic folks below that of white individuals. But more notable, that already large gap between Black Chicagoans and other Chicagoans widened. And so if we break down the gap between the life expectancy gap between Black and white Chicagoans, it is 8.8 years. And when we break down what drives that, chronic disease is by far the largest driver of this gap, and I'll show you the percentage in a minute. Now, this really came to light with COVID, where we see people who have diabetes and heart disease and the underlying chronic diseases, unfortunately, having more severe outcomes and then more death. That's part of what's driving that racial life expectancy gap, even related to COVID. Next is homicide. Next is infant mortality, still, again, one of the strongest indicators worldwide of how healthy a society is. Next, HIV and other infectious diseases. We had written it like this, which is helpful because COVID, of course, falls into this gap, and we'll expect that to move up in this year at least. And then opioid overdoses. So these are not necessarily the 5 main drivers overall in Chicago, although chronic disease certainly leads for overall in Chicago, but they're what drive the gap, the biggest difference in terms of outcomes. And so these 5 outcomes are what Healthy Chicago 2025 are focused around as the proximal cause. But as you'll see, we think a lot about the root causes that underlie this difference. CDPH has very specific goals and the city goals and programming and funding around each of these 5 outcomes. And we are certainly looking to partners in very strong ways across all of these specific proximal causes. But more to the point, we want to get to talking about the root causes. So here is what the actual division does look like. You can see the chronic disease, almost half of the gap, homicide, next at about a quarter of the gap. And then the others do get smaller from there, but all notable in terms of the top 5. And so if we think about what is driving those health inequities, so mortality at the end of the day, that is that almost 9-year life expectancy gap, a racial life expectancy gap. But what's driving that? So disease and injury, chronic disease, homicide, infant mortality, infectious disease, and overdose, like I've just laid out. And if we think about COVID in this term, disease and injury, again, where people have these underlying chronic diseases in particular, higher risk for mortality. If we think about what underlies disease and injury, at some level, this is risk behaviors. So things like smoking or poor nutrition, low physical activity, substance use, sexual behavior. But then about what is driving those, this is when we really start getting into the serious work of creating conditions that allow people to be healthy. So we think about physical, social, and service. And so again, if we take this to COVID, a risk behavior for COVID, that would be things like not being able to stay home, needing to wear a mask, being able to more effectively isolate and quarantine, being able to have enough income that you can actually sustain being able to stay home for 10 days after a positive test, having a job where you have sick pay or family leave, having access to unemployment insurance. So, I mean, this is just putting in the context of COVID, but there are a lot of living conditions that really drive those risk behaviors. And I think COVID has brought some of those to light in very concrete ways. But then what drives different living conditions are institutional inequities. So this again gets at the laws and regulations, like the things like sick pay that I brought up, policies and practices that we have in place in government agencies and businesses and schools and not-for-profits. What can we do to think about how these policies and practices in turn drive living conditions, risk behaviors, disease, injury, and then mortality. And then really underlying those institutional inequities, which are deep and hard to address, are social inequities, starting first and foremost with racism, historic, current, and often I think not as talked about as it should be. And we've really tried to take the opportunity of COVID-19 to talk about it more explicitly, to think about it. I think it's not an accident that the call for increased racial justice after the death of George Floyd on top of COVID, like I don't think it's an accident that these are coming together. We see outbreaks and pandemics regularly being a little bit of a mirror to society and highlighting wherever there are cracks in our social safety net, in the way that we have set up society. And I think COVID has brought a number of these even more to light. So also discrimination based on class, immigration status, ability, gender, and sexual orientation. So although we do have between community areas as much as a 17-year life expectancy gap, and again, you can see here in dark blue where life expectancy is as low as 65 years compared to in the lightest white, where it's as high as 83 years. You see those patterns again. There's a lot of overlap between some of the maps of COVID that I showed and the maps of where people live. So while there's a 17-year life expectancy gap between community areas, that almost 9-year gap is all comers across the city, no matter what neighborhood you live in. And so where we think about getting to these root causes, we're trying to put a lot of this in some more positive terms. So where we think about increased life expectancy, we think about this tree analogy. You see the fruits of the tree here are sort of turning the inequities into more positive things: healthy parents and babies, violence-free communities, drug-free communities, ending the HIV epidemic, improved mental health, less chronic diseases. And then we get there by improvements in things like clean air, vibrant neighborhoods, housing and food access, public safety, health and social services. But to get to those better living conditions, again, really thinking about social and institutional equities and the roots there. So what kind of economic opportunity is available? What kind of fair laws and regulations, public accountability, anti-racist and multicultural organizations? So, we'll send this around. I encourage you to look at it and think about how your own institutions play in here. I think we've certainly seen healthcare institutions doing some amazing work in terms of thinking about offering economic opportunity, hiring people from communities with high economic need, hiring from communities, and doing procurement of materials from organizations perhaps that may not have been the typical organizations that you procure from, really thinking about how are you bringing community voice and power into your institutions. And we've got some really fantastic examples of that here in Chicago. Again, in those root causes, just to sort of take it away from COVID a minute, you think about obesity, which of course has been one of the obvious, unfortunately, factors for higher hospitalization and death rates from COVID. Well, you look at that on the left here in dark blue, are where we've got a higher percentage of adults who are reporting a body mass index of 30 or greater. Well, there is, in comparison here, percentage of adults who perceive their neighborhood to be safe most or all of the time, related to, feeling safe to exercise, to walk, to be out of doors. And then food access barriers, where on the right here in the dark blue, percentage of people who are both low income and then living more than a half a mile from the nearest supermarket, supercenter, or large grocery store. We know there are issues here related to transportation, funding, the ability to stock up on food, and that would be another one, right? Where families are able to shop for groceries for 2 weeks at a time or a month at a time, much less need to be going day to day in terms of food access, either at these grocery stores or even where, as many more people have been out of work, unfortunately, we've seen, of course, much more need for food support. And so the Healthy Chicago themes overall are set out at a very high level to close this racial life expectancy gap. We, meaning Chicago, not just CDPH, will improve systems of care for populations most affected by inequities. And I want to focus on this systems of care, really trying to think about what are the barriers for people to be able to access the care that they need. How can we better coordinate among those of us who provide healthcare, and that's behavioral health, physical health, and the ways in which people are able to access this. We want to further the health and vibrancy of neighborhoods. We want to strengthen community capacity and youth leadership. And we really want to transform policies and processes to foster anti-racist multicultural systems. And I can tell you, really, that means at CDPH taking a hard look at a lot of our internal work, whether that's hiring, our process for grant making, requests for proposals, trying to really look at our own policies and think about where we are, inadvertently adding to the trouble. And so the priority areas are in housing, food access, environment, public safety, neighborhood planning and development, health and human services, and then public health systems and organizations. And obviously, CDPH, the city of Chicago, does not own most of these, but we are working with many partners to think about how work in all of these areas in turn leads to physical and mental health. Focus is the populations experiencing inequities in these different areas. Housing, for example, Black, Latinx, and low-income Chicagoans. Environment, communities disproportionately burdened by pollution. Public safety is more explicitly on Black communities, given what the data shows, and so on from there. And then sort of setting a very ideal state, which we set as a one-generation goal, to have I think a larger goal that we are working toward. So whether that's having a healthy, affordable home, enough nutritious food, breathing clean air, being safe, living in vibrant neighborhoods, benefiting from a full range of services, and then having voice and power in the public health system. This was all pulled together with input from hundreds and hundreds of people and partners and tables and surveys, and really explicitly stating the goals that we're aiming for, even where they're large. And then at the highest level, a city where all people and all communities have power, are free from oppression, and then are strengthened by equitable access to resources, environments, and opportunities that promote optimal health and well-being. And so just to give you a specific example on food, some of the things that we've already been working on, publishing this food environment map. There's a food policy initiative, an advisory group, really thinking about food equity and justice. This really came to the forefront with COVID. And so we've been working, even recognizing the city itself as a large purchaser of food. What can we do to better be purchasing that food from local suppliers, to be thinking about healthier food within that, but also what opportunities are there for economic growth in neighborhoods where that's most needed. So just to give you sort of a specific example, these are our guiding principles. Again, we'll send this around, but really trying to, really actively talk about anti-racism through process and strategies, trying to be asset-based, equity-focused, trauma-informed, thinking about capital building quite explicitly, and then trying to be community led. I think these are high level, but we do try to return to them and think about where are we falling short? How can we, in all of the planning and work that we're doing, continue to think about this? And so public health looks like this, certainly testing and reopening businesses and, sharing data. And we have worked very hard, again, to try to keep the Healthy Chicago 2025 initiatives in line. At CDPH, for example, for our contact tracing, we've contracted specifically through a lead agent with 31 community-based organizations explicitly coming from the neighborhoods that have high economic need in Chicago, hiring people from those neighborhoods and doing an earn as you learn program so that people who are doing contact tracing also have the ability to earn some credits through city colleges of Chicago. Our goal is that these folks will eventually, some of them, be able to transition into more long-term community health worker type work or outreach work for Healthy Chicago outreach well beyond COVID, even while right now they're involved in a lot of the COVID work. But also public health looks like this, the kind of work that we're doing for renters, thinking about the economic recovery work, which is going to be crucial, this emergency food coordination center, the Together Now grants for small businesses and nonprofits, and people just stepping up. It's been an amazing year. It's been an awful year, but it's been an amazing year to see how Chicago has really stepped up and come together and thought about how can we take some of the progress that we've made, whether it's working with homeless, people who are experiencing homelessness, whether it's people who are experiencing food insecurity. A lot of this has come sort of to a crisis point with COVID. We want to take those learnings and then have them become something that outlives COVID. And I encourage and hope that all of you in your own institutions and work are thinking about that, where you've changed your procedures. Why have you done that? How have you done that? How can you take some of the learnings from that and have them outlive COVID? My goal, and I think it is entirely possible, is we will have a stronger and healthier Chicago as a result of COVID, as long as we can double down on some of the things we've learned now. Vaccine is coming. This is one of my CDPH colleagues' daughters who has heard her mom talking at great length about our vaccination planning and had set up a vaccine clinic here. You can see the mask for the elephant in the lines, but really we're very, very focused on thinking about what vaccine looks like with these Healthy Chicago 2025 principles in mind. And so I'll just finish by showing you a couple last maps. We are starting with healthcare workers in Chicago, and we did this same census work looking at breaking down healthcare workers. So where we look at where people in Chicago live who are what are called healthcare diagnosing and treating practitioners. That's our physicians, surgeons, nurses, pharmacists, therapists, dentists, for example. We see there's a lot of concentration right around the loop. There's more living on the north side, not as much on the south and west sides. When we move to health technologists and technicians, that would be our EMTs, our paramedics, technicians, dental hygienists, we see that is quite widespread actually across the city, although less on the north side. And then where we look at healthcare support, these would be our home health aides, nursing assistants, orderlies, phlebotomists, people who draw blood, dental assistants. We see a lot of focus there on straight west and straight south Chicago. And so we are using maps like this as we think about our planning, even as, the current, we're starting with healthcare workers in Chicago. There will need to be more outreach, more work to reach this third group, recognizing that this is the group, again, making lower wages typically, more disproportionately Black, Latinx, and more barriers simply to being able to access vaccination. And so we are really trying to think right from the get-go about the inequities we expect to see, frankly, within vaccine uptake. And I can talk more about this if people have interest, but our final Protect Chicago is our initiative, which right now has been about making sure both at the citywide level, but in a very focused neighborhood, like in the census tracts that are being hardest hit by COVID, we've got safe passage workers out, like going door to door to door, making sure people have the information they need about COVID, about how to protect their family, how to get tested. And then the vaccine will be at the heart of Protect Chicago. So once we start to move beyond healthcare workers and we start to see expansion expansion, you'll be hearing much more about our Protect Chicago work. But we are really trying to take the Healthy Chicago 2025 values that were laid out and use them in practice really every day in the COVID response. And it's, it's a learning curve, but I am very glad that we had done that work in collaboration with so many partners, because it's been pretty remarkable actually how easy it's been to overlay a lot of the very specific planning, whether it's testing, whether it's outreach, whether it's vaccine, to these same principles. And I'm hopeful that we will certainly have a successful vaccine campaign here, and we'll be starting, looks like, later this week. So that's what I had to share. Thanks again for the time, and I'm happy to take questions.
Thank you so much. That was super informative. And I also just want to point out how busy you are. So we really appreciate that you are here with us right now, spending an hour of your time educating us. And hopefully it can give us some activities and things to think about on our end so we can be helpful. So I love to, as you said at the beginning, we want to make sure that we're talking about the pandemic, but also kind of forward thinking. That's part of the goal of our transformation series, is to think about how HC3 and our members and partners can engage to really continue to build out of this situation. So during the live stream launch in September, you said we are being even more explicit in the work and the planning than ever before. And we can definitely see that. So we certainly recognize that racism is at the heart of many of these inequities that we are talking about. So tell us some of the differences in how the implementation of this plan, especially amid a pandemic, really contrasts to what are some of the highlights and differences between the Healthy Chicago 2.0, and what are some of the big expectations that we see as far as real change in these new iterations of the plan?
Yeah, absolutely. So I think for those of you who every 5 years, the health department, we are required, as is every accredited health department, to do a new plan involving a lot of community input. And we first used Healthy Chicago as that name about 10 years ago now. And that was the first time that we started using data in a serious way to say, where is Chicago ahead? Where is Chicago behind? Trying to really think about some focus areas. With Healthy Chicago 2.0, which was what took us up to 2020, that was the first time we started calling out health equity. And by that, we were tracking a lot of indicators. We continue to track those. The work of Healthy Chicago 2.0 sort of doesn't stop, where we're following more than 100 different indicators. And we started defining success, not just as was the city as a whole doing better. So, we had identified smoking, right? Obviously, as something that we were going to focus on back in Healthy Chicago. In Healthy Chicago 2.0, we said, let's actually look at not just is Chicago doing better, but what are the subgroups within that? And so in 2.0, for example, even if you look at youth smoking, LGBTQ youth, we're smoking at a much, much higher rate than sort of other youth. And so we said success is not just, is youth smoking getting better? It's like whoever the furthest outlying group is that group moving closer to the mean? And so if you take uninsured Chicagoans, I think it was, Latinx or Hispanic men between 25 and 34 were the group least likely to be insured. And so we started to define success, not just as like, was Chicago as a whole getting better, but was this particular group moving toward the center. The big difference with 2025 is that we much more explicitly call out race. We did that, I think, partly because under Mayor Lightfoot, this administration is really very much talking about this and the long history of underinvestment in parts of the city. And a lot of her goals are also about thinking about this from an economic perspective and being able to tie that sort of into the health outcomes. But we also wanted to be a little bit more focused. So while we continue to follow all of the 2025, the 2.0 things, we said, what are the 5 main drivers, in the proximal way? And that lets us sort of say, there's so many things that we could be focused on, but these are the things that for the next 5 years, we really as a city want to make sure we are explicitly kind of calling on our partners also to really help with. And so while we work on those proximal causes, it's again, all of the underlying work that comes with it. But it was just a sort of a chance to, I think, be a little bit more focused. I think the other big thing is that we have very much, I think with 2025 and with COVID, have turned a lot of attention, I mentioned this briefly, but to our internal processes. So CDPH hired for the first time a deputy commissioner focused on race equity, like at the health department. What do our hiring practices look like? What do our grant making look like? Where are we not offering opportunities? Where could the city be doing better in terms of investments? Like this kind of more structural work, really looking at what are our own policies, where are we not reflecting, what we are encouraging sort of the city to do, and being really open-eyed about that. And I think, I would encourage, all of you too, to, as you're thinking about this, as you're thinking about what kind of messaging you're bringing, how are you thinking about that in your own institutions with your own staff? Are there ways that you can work on some of these same principles within? And I think COVID has, again, we were not expecting COVID, of course, when we were planning this or launching it. But it has brought, every single week we are looking at these pretty specific outcomes by race, ethnicity, neighborhood, and saying, how can we do better? How can we pull in other voices? So we think it's important to talk not just about health equity, but about racial equity in where we are at this point in Chicago and in the US. So that can be uncomfortable for some. As a white woman, it's not my most natural place to sort of start speaking from. But I think recognizing that, I, as the leader of this institution, sort of need to make sure that I am not afraid to talk about that, and recognizing that I am often not the best voice about it also, right? And so making sure we're pulling in a lot of other voices and leaders, recognizing I do not, have that same personal connection to it, but we as a city have to talk about this and have to work on it if we're ever going to be serious about getting past it.
Yeah, you definitely started to touch upon my next question, which is really that health and social and racial disparities have become a focus, especially because of the pandemic, especially because of current events this year. But equity is a huge part of that, and it's something that you started to talk about, how CDPH is investing in actual roles to oversee that. What are some of the other things that you envision as far as activities to really influence equity? And then bringing in one of the questions from the audience is just, how is this flowing down to those neighborhoods, and how are these initiatives then coming into the fold?
Yeah, so there's a number of things. So again, where I think about the CDPH work specifically, like if we take those 5 sort of major outcomes, if you take infant mortality, for example, right? We are working, for the first time, there are these community advisory boards that are, there's a regional group across the city pulling together tables of people with interest in this. So there's people who are already working out, but there's also community members, and it's sharing data sort of for that region out, and then developing very sort of localized plans around, we're launching something called Family Connects, which is a goal where every baby that is born in the city of Chicago in a hospital certainly gets some nursing care initially in the hospital, but the idea is would also see somebody in the hospital, a nurse in the hospital, who then is following up at home about 3 weeks later. And in that home visit, it's a pretty long assessment of what does this family need? What does the mom need? What does the baby need? What does the family need? It's not a sort of forever and ever follow on, but it's this link to nurses being some of our most trusted professions in Chicago from a public health perspective, then sort of bringing these needs back to the community advisory boards, thinking about how can we link up to existing community-based organizations, what needs more funding, how can we be coordinated, and having this really be a very community-driven opportunity to see data for, in a way that protects individual privacy for the moms who are giving birth who live in that community. Where are the needs? How can we be more coordinated? So there's things like that in each of these areas. And I could talk in some more detail, but trying to really be explicit about what does it mean for CDPH to share this data, but then to get the input and the decision-making very much from community. For even where we take COVID, for example, every week, we share out, here are the zip codes or the census tracts where we're the most concerned. Here's where we're seeing cases surging. Here's where we're seeing high positivity. And then it is actually, the race equity rapid response team and the advisory group that is saying, okay, here's where you should have a mobile testing site. Here's where you should do this here. Like this, trying to be even more intentional about really listening to the experts who know their community and know how resources can be best invested, and trying to really bring resources. I think that it's, where you talk about some of the homicide work, for example, like if we're not truly investing in violence prevention programs, if we're not really thinking about how victims of violence and communities can be linked to mental health resources, like it's all just talk. And so we've been trying to be quite explicit. There's been new investments in the city budget around that. Certainly where we're trying to think about coordinating and bringing together health systems. A lot of that is we think the behavioral health space, frankly, has a lot of the greatest need for that here in Chicago. So we're trying to do more around linking together outpatient mental health, crisis mental health responses. What are we doing for people who are repeatedly, people who are experiencing homelessness or substance use, frequently cycling through the system? How can we at a systems level, again, that's kind of the public health sweet spot, work with our clinical providers to sort of be coordinated. So those are just some of the examples. There's more details kind of on each of those 5 priority areas.
So, and CDPH is not in the business of being a clinical owner anymore. You have sort of divested in that and are really relying on these systems and the hospitals. So, given that there are so many hospital systems, and a lot of what you talked about was community engagement, and I know that there are many representatives on the committees that you have from the hospitals, but with so many disparate systems, what is the city doing to sort of be that mediator and that medium of facilitating some of the things that get decided, like a vaccine distribution site should be here, and how are you all kind of bringing some of that together?
Yeah, so that's a huge and really interesting question. So CDPH actually does continue to provide some direct services, although it is not our primary role. We still, we operate 5 mental health clinics, we operate some STI clinics, immunization clinics, tuberculosis, et cetera. But it is, and then some of our family nursing outreach, that kind of work. We also operate direct nutrition stuff. But most of our work most of the direct clinical work is very much in partnership with both outpatient and inpatient providers. So I think a couple things. COVID, again, has been very helpful in terms of trying to be as coordinated as we possibly can be. I think the hospitals certainly were a very natural place for that. And again, huge thanks. Our Chicago hospitals have stepped up in amazing ways. There are 34 hospitals here in Chicago between acute care and specialty care, not counting behavioral health. And so all of them, have been part of really, depending on sort of the phase of the pandemic, we've been in weekly or more conversations at different levels, whether that's with sort of leadership and medical, nursing, logistics, data. We've worked to really try to modernize and are still working hard with a lot of partners. Rush University in particular has been a huge leader here in terms of helping kind of pull together data so that hospitals are able to understand better what's happening, across the whole system, where we think about, the potential of running out of hospital beds, that kind of work, like being able to have that more widely available. I think on the outpatient side also, we've been pulling together, our federally qualified health centers are our most natural clinical partners in terms of, who the populations that they are funded to particularly provide service to. But and we regularly work with all of the vaccines for children provider. We've got more than 400 vaccinators that we regularly work with, but COVID has meant that this has expanded out a lot more. And so we try to think of ourselves as a relatively neutral convener in this space. We think a lot, even from an equity standpoint with vaccine, for example, we decided here that really from the get-go, we wanted vaccine available to all 34 of our hospitals, like really right away, like from the beginning in the first week or so, recognizing that there are some that have a lot more capacity, have the ultra cold storage. There are some that are much smaller, may not have some of that. And so CDPH is sort of helping to support on the distribution side and some of the logistics side, some of the smaller hospitals, while making sure that the larger hospitals are able to get vaccine, all at the same time, basically within, the same week or two. And then working sort of within those hospitals also to think about, who are the healthcare workers that you are prioritizing? Hospitals get to make their own decisions, that we don't regulate hospitals, but we provide sort of guidance around that. And then often, I mean, in the vaccine, we will literally be distributing vaccine there. And that's only going to get more complicated as we start to move toward outpatient healthcare providers, and then, to the stages that come on. But I really have appreciated, we had a vaccine scientific work group, for example, that came together, a lot of leaders from around the city, many from academic institutions, some from others, really helping us look at the FDA process, any concerns there, weighing in on some of the science of this. Every time that we have asked for input, people have been very willing to not only give advice, but really try to think about what can we do as a whole city, and putting equity really at the center of it.
Yeah. So, I mean, and so someone asked in the chat, will participants receive a list of opportunities of how to volunteer? And really, I mean, inevitably, our silos need to be broken down. A lot of what CDPH has done really well during this pandemic is between the community, between the health hospital systems, really kind of coordinating all of this and being that guide, as you just mentioned. But what are the opportunities that you see for public and private partnerships for us to really kind of help you move the needle and actually achieve these goals?
Yeah, so I'm just typing in a couple of little email addresses here into the text, and then I'll so two things. So for any institution that is not already connected to Healthy Chicago 2025, you can Google it, you can find it, you can learn more about it. But I also put in the email for Janice Turner, who is our lead for Healthy Chicago. And so if your institution is not connected, you want to make sure you're at least on the work groups, you're sort of, getting pulled into that messaging and that fold, please do reach out to her. But then also specifically around Protect Chicago, on chicago.gov/coronavirus, which is our landing page for all things COVID. And I hope people know that page. There's a vaccine tab, we continue to update it a lot. There is a Protect Chicago tab. And so where people have interest in volunteering, they're taking people who are even interested in, helping with social media and texting, et cetera. That will be an opportunity, on a more individual level for people to sign on. And there will be plenty of more opportunities for a lot of partners, especially in the vaccine messaging space. We recognize as we sort of move ahead, we will be looking very hard for trusted healthcare workers who either live or work in a given zip code and who have taken the vaccine and have some knowledge about the vaccine, who are willing to partner with community organizations, churches, CBOs, community groups, neighborhood groups, and be willing to sort of come together in a virtual way to answer questions, to help talk openly and honestly about the vaccine. You'll see on that website, if you go to the vaccine tab, we already have put up quite a lot of information that you can use right now around what to know about the vaccine. We plan to sort of be updating this daily. People can take it, adapt it, put your own logos on it. It is free for use. But I am really interested in people being able to use this and really make sure we're all singing from approximately the same playbook, but that you're then adopting it for your population.
Yeah. And so, we've already seen this is the first day that we're going to start seeing the vaccine actually start to appear across the nation. So it's an exciting time. And as you said, there's a lot of different scenarios and planning as we kind of peel back the layers of who's getting it and when. Especially a lot of distrust is a concern for people. And I know I am a frequent flyer of the CDPH website, so I'm well aware of all the different resources, but what are some of the things that you're trying to do to help make sure that there's an equitable focus on the distribution?
Yeah, so there's a few things. So first, we are, they've just started shipping vaccine yesterday. It will be rolling out kind of over the week or so. So I think, we are anticipating we may start to see some of the first doses here, but I think it's going to be probably later in the week before we're start to vaccinate in a serious way. But it's super exciting. It's like this week it's starting. And there's a lot of training and kind of other, logistic pieces that sort of go into this. But I think we will be, there's just going to be a lot of pieces of this. So we are, I feel like I have to say, really expecting that at the federal level, there will be additional funding put toward distribution and messaging around COVID vaccine. It still has not been agreed on at the federal level. And so, although billions of dollars have been put into the production of this vaccine, and I'm thrilled that it's here, it's been about $200 million across the whole country. And here in Chicago, we've received about $3 million at this point toward vaccine outreach, communications, logistics, distribution, et cetera. We are using some of our other COVID money in the meantime, but really like anticipating that this will come soon because it's a huge operation. So we will be using some formal, given how big this outreach is going to be, there's going to be, and you'll hear more about this sort of over the week, but we are working with some formal communications partners, including some that have expertise and focus in reaching Latinx communities, Black communities, et cetera. That's going to be a lot to come. We're talking with the philanthropic community about moving the on the table conversation. If people are used to this, it's this idea that the whole city is sort of having a conversation at one time, probably moving that up to about February and having it be a very vaccine focused, all parties on board. Let's talk about this honestly and openly. Let's talk about this history. And I think particularly among Black Chicagoans, we are not at all taking for granted that people will be excited about taking this vaccine. We know, there's this really, unfortunate and true history about experimentation, decades back and not decades back, among in the Black community. One of the good things here is that we've had actually quite good diversity of, meaning racial and ethnic diversity, among people who have participated in a lot of the trials, especially the Moderna trial. Like out of UIC, for example, about 75% of the people here in Chicago who have been in that trial were not white, which is very high compared to a lot of the country. And we're lucky to have a lot of racial and ethnic diversity among the people who were leading the trials here too, I think, and a lot of really prominent physicians and others who are Black and are willing to sort of talk about their confidence in the vaccine, and we'll be wanting to sort of highlight some of those voices early on. We're also not at all taking for granted that healthcare workers, especially using the broad term healthcare workers, will be excited about getting that vaccine. That map that I showed of where home health aides live, for example, where you look at data, there is, broadly across the country, overall, Black Americans say they're less likely right out of the gate to want to take this vaccine. But the other predictor besides race ethnicity is education. It really is striking, both for what our flu vaccine uptake looks like normally and what the predicted COVID vaccine is, that where you start with people who with less than a high school education, it really goes up significantly. So people who have more education, much more likely to be interested in taking the vaccine. And so as we're thinking about what our outreach looks like and what our comms and all of this, wanting to make sure that we are, at a literacy level, at a conversation level, reaching, all Chicagoans, and trying to think also about answering questions, for people who may not have as high health literacy. So there's a whole bunch of pieces in this. We will be reporting out vaccine uptake. We plan to report it just as we've done for cases and testing and all the rest of it. We plan to do it by neighborhood of where people live, by race, ethnicity, by age, by gender. I expect that we will see inequities in there. I think it would be foolish not to expect that. And right from the beginning, we're already message testing among Latinx and Black Chicagoans. We're thinking about this, thinking about champions, and then we'll be looking to grow a really grassroots kind of campaign here, focusing on trust and trusted voices within communities.
Taking just a broader picture look again, just kind of zeroing away from the pandemic, what are some of, in your opinion, as you've set out, like there's another 5-year plan and we're still kind of grappling with our day-to-day. So what are some of the most daunting challenges outside of that, or because of that, that you foresee? Are there opportunities or solutions? And like, if so, are people here, part of HC3 membership and partners, able to help with that in some way that maybe CDPH doesn't have the answer, maybe somebody on this call does?
Yeah, absolutely. And right. And the reason, the Healthy Chicago plan is not really meant to be CDP. It doesn't say CDPH on the cover. It sort of talks about Chicago overall, and really all of you in this. I think we have seen certainly the pandemic exacerbate some of these other things in interesting ways. Opioid overdoses are at just unfortunately record highs also. We've seen increases in gun-related violence, homicide, actually all kinds of violence, domestic violence, some of this thought to be related to, again, just, increased economic stress, increased stress in people's lives. And so and then even where you think about things like infant mortality, people have not perhaps been getting all of the prenatal care that they might have prior to COVID, HIV, although there's been a lot of work and we've generally worked hard to make sure people stay in treatment. We just know, and then chronic diseases, right? I mean, my goodness, where people are not getting their care for diabetes or they're worried about COVID, it's a very destabilizing time in general, I think, for healthcare. And so we are, very interested, and those of you who especially have work in the behavioral health space, that's where we're very focused. We're trying to think more creatively about, what does follow-up look like after opioid overdose? How can we link more community health worker types and peer workers into some of these different spaces? If you feel like you are not connected to conversations around any of these outcomes and you're doing interesting things, Jenny Turner is a good place to start. We'll get you LinkedIn. There are ongoing sort of work groups and thinking about this. We don't have all the answers at all, but we are very much trying to think systemically, and want to highlight where you all are doing good work in this space. That's the other thing. If you've got interesting work that's got an equity focus, especially in those 5 areas, and obviously in COVID, we would like to help sort of think about that. And I think especially when it comes to root causes, right? Where I've loved, West Side United and others really thinking about how are we not just working on this proximal stuff, but real economic opportunities, jobs, education, some of the more long-term investments in communities. We're especially excited in helping, support that, think about, we can hook you up with others who are doing interesting things in that space. And sort of as a community, think about what does it mean to seriously think about wealth gaps too, and where do we go? So we really again see ourselves mostly as kind of a broker of partnerships, and a good provider of data, and want to be supportive to all of you in any way that we can as you develop your own initiatives.
All right, last question. Last week, we had the pleasure to have Dr. Ashish Jha join us, and he pointed out that this is an age of pandemic. So what are we going to do better to continue to prepare for the worst, for more waves of this, for what can we as a city do to help bolster and advocate for better coverage the next time around?
Yeah, so I mean, I'm being totally honest. We here in Chicago were probably the best prepared of any city in the country, just honestly, and it still wasn't enough, right? And so I think where, we actually had stockpiles of PPE, like millions of N95, like we had done a lot of this that it turned out a lot of jurisdictions, cities, states, et cetera, just had not done. I have a very strong emergency preparedness team here that's been thinking about, started thinking about immunization back in February. Like a lot of that logistics stuff is relatively strong here, I would say. But what for me, this has highlighted a couple things. One is just, we are super underinvested in public health. Like, for every dollar that we spend as a country in healthcare, like 1 penny of that is in public health, right? And about 99 cents of that is in healthcare. And all of the work of preparedness really does fall mostly to public health. That idea rose after 9/11. And we need to be thinking about not just sort of the stockpiling, but like the supply chains, right? What are we doing to make sure those are not interrupted in the ways that we saw with such unfortunate related to kind of the testing issues? Data is huge, like major investments in updating all of our data systems. We're like 20 years behind. I mean, we've progressed a decade in the last 6 months here, but a huge way to go, not just in public health, but I think across healthcare in generally, about interoperability. How can we make sure that, in our country where we do not have a universal healthcare system, there are reasons to make sure that there is the ability to share, so clinicians are able to understand care that people get in other parts. Vaccine, that's been a huge thing. You want to make sure people are able to understand whether somebody's been vaccinated, regardless of where it was done, how it was done. We don't traditionally, as a country, build in that way. And this has highlighted the major need for much, much better coordination with appropriate privacy and all the rest safeguards in that space. So I'm really looking for more investment, again, more federal mostly investment to really build some of that up and support hospitals. And I think, the other thing is just how our social safety net, right? Like it wasn't by accident that I mentioned things like sick pay and family leave and unemployment insurance and what are we doing for undocumented folks, that like where this has caused a problem, I think we need to say, what should we do as a society, whether that's at the city, at a state, at a national level, to make it so that if somebody is sick, for goodness sake, they can stay home, right? And like not spread whatever. We don't have a system that allows for that, honestly, for people who are living kind of day to day. And I think this has really highlighted a lot of the gaps in our social safety net. So I'm hopeful that there will be big conversations nationally and here around some of these larger policy type issues, and just advocating, please, for additional public health funding. We need it if we're ever going to be in a really solid place, looking ahead, not just towards vaccine, which is my immediate concern, but towards being as prepared as we can be as a system for whatever comes.
Well, thank you. We're just a little bit over time, and I want to thank you for spending those extra minutes with us because we know how time is valuable for you right now. We're really grateful that you were able to share with us today and for all the work that you've done on our behalf for our city this year. As I mentioned at the beginning, I don't think we could have fallen into better hands at the beginning of this year. So thank you for stepping up beyond what I think anyone expected. And we are all grateful and appreciate it. So on that note, thank you, Dr. Arwady, and thank you everyone for joining us. This is actually our last webinar of the year. So thank you all for joining us. We will pick right up after the holidays, but I want to wish you all a happy and safe holiday season, to just make sure you socially distance and wait out that vaccine. And we'll see you all in 2021. Thank you.